So welcome everybody to a session with me. Welcome to Exam Slayers 911. In this episode, we're going to speak about an approach to chest pain. Okay, so we have over there chest pain. Sorry for my handwriting. Okay, so my approach to chest pain. So I'm gonna ask myself a question. Okay. So a patient is coming in with chest pain. Okay, so firstly, I want to know, is this chest pain, is it an emergency? So an emergency, or it's not an emergency. Okay, it's not an emergency. So how do you know if the chest pain is like definitely this is an emergency and it needs to be sorted out? Just gonna check another color. So if we know it's an emergency, you will have to check vitals. The patient comes in and the nurses obviously have to take vitals. So if the respiratory rate is more than or equal to 30, then you know, okay, this is an emergency. If the blood pressure, right, is more than or equal to 180 over 130. So here the patient is quite hypertensive. And then, or the blood pressure could be hypotensive, where the blood pressure is less than 90 over 60, right? In terms of the heart rate, the heart rate is more than 100, then we would say, okay, this is an emergency. So it's tachycardia if the heart rate is less than 50. Then you know, okay, this is definitely a bradycardia, right? So that's in terms of your vitals. Then also in an emergency setting, patient will say, doctor, I have severe pain. So for the patient coming, patient will say, doctor, the pain is severe. Okay, so severe is a very important keyword. Okay, new pain or discomfort in the center or left side of the chest. So I'm going to put here, so I'm rather going to classify this as Socrates, right? So let me just take that away. So I love to use this acronym called Socrates. So S stand for site of the chest pain, O is for onset of the chest pain, C is character, R for radiation, A for alleviating factors, what takes the chest pain away, T is for timing, how long it lasts, and E is for any exacerbating factors which have led or makes the pain worse. Okay, so that's Socrates, right? Um, the first is, so in terms of whether this whether this chest pain is an emergency, severe pain. So in terms of the character, if the character is severe, then you know, okay, this could definitely be an emergency. If it's the onset, so the O is for onset of chest pain. If it's new, right? If it's new, then we know, okay, this is an emergency, right? Discomfort in the center or left side of the chest. That's in terms of the site or the location of chest pain. We know that if it's central or on the left side of the chest. Um, so I'll just put here as a keyword to remember the word center. Okay, then pain radiates to the neck, jaw, shoulders, and arms. So R for radiation. So I'll just put the radiation. Okay. Um, So the radiation is obviously to the neck, arm, jaw, right? To the neck, arm, jaw, shoulders, arms. Then associated symptoms, okay, it's alleviating, timing, exacerbating factors. Associated symptoms could be nausea and vomiting, especially for an emergency. So I'm going to go a bit down. So nausea and vomiting, right? Pallor and sweating. So pallor and sweating. Okay. And then known with ischemic heart disease. So it's another important factor. Ischemic heart disease known. Okay, so we know that this patient has ischemic heart disease. So the patient, no, it needs to go, you have to do this MI. This could definitely hold that there's an emergency. Okay, and then the risk of an MI, right? And myocardial infarction risk, risk factors, right? So risk factors to take into consideration is for myocardial infarction, it's definitely has to be hypertension, definitely there has to be diabetes mellitus, uh, definitely has to be high cholesterol. So cholesterol, so high cholesterol, definitely have to be smoking and alcohol. Okay, sorry for my handwriting. That's alcohol. Okay. Let me just erase that. Okay, so it's all okay. So alcohol, smoking and alcohol, known CVD risk of more than 20%, as well as family history. Right? So you have to check your cardiovascular disease risk. If it's more than 20%, then you know, okay, could be the chest pain is very it's an emergency, and then also family history, right? The patient have a family history of chest pain, but obviously in an acute setting, it's very difficult to discern whether the patient actually has a family history, right? So we spoke about we started saying, okay, chest pain, either an emergency or is it not an emergency? To know whether it's emergency, you must look at the respiratory rate, blood pressure, as well as the pulse rate. Look at Socrates, right? Terms on site of location and center. Could radiate, so it could radiate to the neck on jaw. The onset is quite new, rapid onset, gradually worsen. It's very severe pain, so yeah. Associated symptoms, nausea and vomiting, pallor and sweating is known as ischemic heart disease, has a mild risk factors such as hypertension, diabetes, cholesterol, so again alcohol, has a CVD risk of more than 20%, and also have a family history. Okay, so now we know, okay, this chest pain is definitely an emergency. So the first thing we do, right? So the first thing we do in an emergency setting, right? So now, okay, first thing we're going to do is an ECG. Okay, so we're going to just change the color. Okay, cool. So emergency versus not emergency, very important ECG, right? And this ECG could either be a normal ECG, so a normal ECG, or it could be an abnormal ECG. For a normal ECG, or basically if there's other abnormalities or unavailable or you're uncertain about the ECG, then you have to ask yourself another question. Okay, so you ask yourself another question. You ask yourself, is the ECG, is the chest pain worse on lying down, palpation, or breathing deeply? Okay, so is the chest pain there? So does the patient have chest pain while lying down? All right, lying down. Um, palpation, right, during palpation, or breathing deeply. Okay, so is the chest pain worse when lying down? Is the chest pain or on palpation or breathing deeply? Okay, if the answer is yes to that, okay, if the answer is yes to that, patient most likely have ischemic heart disease, right? Well, no, that is if it's no, right? So, yeah, okay. If the patient do have these symptoms, so it's yes, okay. So remember, chest pain, if it's a normal ECG and it's chest pain while lying down during palpation and during patient breathing heavily, we need to manage and refer urgently. Okay, so two keywords I have to remember. It's manage and refer. Okay, manage and refer. And this is an emergency setting, an acute setting. Okay, and how would we manage this chest pain? If oxygen saturation is below 94, not available, respiratory rate more than 30, or difficulty breathing, give face mask oxygen. Okay, so management is for oxygen, right? So when do we give oxygen? Indications for oxygen is when the SATS is less than 94%, um, when the SATS is less than 94%, or the respiratory rate is more than 30, right? Or there's basically just a difficulty in breathing. Okay, then you would give the oxygen mask. If sudden breathlessness, more resonant or decreased breath sounds, or pain on one side, deviated trachea, right? Tension in the thorax, likely. Doctors to insert a large bore cannula above the third rib in mid-clavicular line, and arrangement for current for urgent test tube. Okay, so let me just have a look, right? So in terms of the management, um, so that's just the features for tension in the thorax. If the blood pressure, if the patient is hypotensive, so let's say the patient is in shock, okay? So this is managing the blood pressure, right? If you have high blood pressure, you can have low blood pressure, right? If it's high blood pressure, give a single dose of amlodipine 10 milligrams orally. Okay, so you give an amlodipine. Okay, so we give amlodipine 10 milligrams per orally, right? Um, and then if the blood pressure is low, we give sodium chloride. Sodium, we should have a look. Sodium chloride, okay, and it's 0.9%, 0.9%, 500 moles IV. Okay, so that's what it is for. Okay, so for low blood pressure, you give sodium chloride 0.9 percent, 500 ml. So sodium chloride will draw water into the intercellular space. Um, Oh, no, wait. Chloride, yes. Chloride is going to increase the blood volume. So it's going to draw water into the blood. It's going to retain the water. What's going to lead towards retention. Then it's going to increase the blood volume. It's going to increase the blood pressure. If the chest pain is worse than breathing deeply, coughing, sputum, and temperature, then you have to think of pneumonia. Okay, so we speak about oxygen. Okay, speak about oxygen therapy, right? If the respiratory rate is more than if the respiratory rate is more than 30. So I don't know where this number came in. If the respiratory rate is more than 30. Okay, speak about the blood pressure. Is the patient hypertensive or is the patient hypotensive? Then we try to manage. We also ask the question, why is this person having shortness of breath? Okay, so the shortness of breath, right? Um, okay, so most commonly, right, if it's pain on one side only, okay, pain on one side, and you auscultate that side of the lung, and maybe you can't hear any sounds, then you have to think of a tension pneumothorax. Okay, and how do you treat the tension pneumothorax? For tension pneumothorax, the doctor has to insert a large bore cannula. So basically a chest tube called an intercostal drain to drain out that excess air. Then again with the shortness of breath, right? So if this shortness of breath is associated with coughing as well as a fever, you must think of pneumonia, right? I have to think of pneumonia, and if it's pneumonia, we're going to give ceftriaxone, which is going to be 1 grams IV or intermuscularly. Okay, so then referrals, that's an important thing on its own. Okay, so we spoke about ECG. That's normal, abnormal. If the ECG is abnormal, you can have maybe an ST elevation, ST depression, maybe spinal branch block. All these are uh, part and parcel of leading to, or what could have been, um, remember the, yeah, ST elevation, ST depression, left bundle branch block, all of these are the causes or things which ischemic heart disease actually cause. Okay, so Just going to choose green again. So an abnormal ECG could definitely, we have to prompt for ischemic heart disease. Okay. And an approach to ischemic heart disease is very much, we're going through that in another session. Um, so we have an emergency and we're kind of done with it in an emergency setting. Okay, so very, very, very important to comprehend and understand. So for chest pain, it could either be an emergency or not an emergency. If it's an emergency, we think, okay, patient could either be in shock or there's just a spike in a whole lot of the vitals. So check the vitals, check the respiratory rate. If it's more than 30, it's urgent. If it's less than 30, it's not an emergency. If the blood pressure is more than 180 over 130, it's an emergency. It's hypertension. If the blood pressure is below 90 over 60, it's hypotension. It's an emergency. If the patient is a heart rate of 100, it's tachycardia. It's an emergency. Heart rate of less than 50, bradycardia. It's an emergency. Socrates is very, very important. Emergency factors for in Socrates, if the chest pain is central, it's a new onset, very, very severe, it's radiation towards the neck, shoulder, and left arm. Okay, if there's associated factors such as nausea and vomiting, pallor and sweating, patient is known with ischemic heart disease, patient has MI risk factors, hypertension, diabetes, cholesterol, smoking and alcohol. The patient has a CVD risk of more than 20% in the family history of ischemic heart disease. These are factors which prompt an emergency chest pain. Okay. In an acute setting, you go into the ECG. If the ECG comes back abnormal, such as there's a ST elevation, there's a bundle branch block, then you're going to see, okay, could definitely be ischemic heart disease, and then there's an approach to ischemic heart disease. A normal ECG, if the ECG comes back normal, right, you ask, is the chest pain there while lying down? Is the chest pain there during palpation? Uh, is the chest pain there when you have shortness of breath? If it's no, then it's skin disease. But if it's yes, then we have to manage appropriately. Okay, so very important, give oxygen. Okay, first less than 94, the rest is 30. Right? Blood pressure. If it's high, give amlodipine. Right? And what is amlodipine? Amlodipine is a beta blocker. It decreases the blood pressure. If there's hypertension, so you give sodium chloride, 0.9% 500 ml IV. If the patient is shortness of breath, you ask two questions. Number one, is it paining on only one side? Number two, do you cough? Do you have a fever? If it's pain on one side, it's tension in the thorax, it's the ICD. If they had fever, you think of pneumonia, give ketraxone 1 grams IV or intramuscularly. Okay. Then if it's not an emergency, right? So in this case, don't have an emergency. Okay. So if it's not an emergency, like you have recurrent episodes of central chest pain, put on by exertion and relieved by rest. Okay, so ischemic heart disease again. Okay, so okay, so there's different factors when you think of that it's not an emergency. Okay, so not an emergency is obviously it's opposite. If there's none of those other factors in which it was an emergency. Okay, so regarding the chest pain, right? So we have one, two, um, one, two, three. Okay, so let's say I have three branches for not an emergency. Okay. If it's not an emergency and we know that the chest pain is central, we know that chest pain is exertional. So it's central, it's exertional, and it's relieved by rest, right? So it's a rest reliever, okay? So central exertional and rest reliever, you have to think of ischemic heart disease, okay? If the patient has retrosternal or epigastric pain with eating, hunger, or lying down or bending forward, okay? So retrosternal, um, lying down or bending forward, that would prompt you to a dyspepsia, right? Or gastroesophageal reflux disease. Okay. Then, if the chest pain, right, the layers covering the chest, the ribs covering the chest, if you suspect tender tender at the costochondral junction, right? So tender in costochondral junction, right? Test the tender at the costochondral junction, and there's no fever and no cough, right? So then you're gonna have to think about a musculoskeletal problem. Musculoskeletal problem. Okay, cool. So for dyspepsia, what we're gonna give for dyspepsia, so in terms of the management, IHD is a separate thing on its own. So for dyspepsia, very important that the patient have to stop all NSAIDs. Patient must stop smoking. Patient must reduce in the alcohol and decrease in the caffeine, right? Another management is the assessing the seriousness is fine. The lansoprazole, right? And lansoprazole is a protein pump inhibitor. Okay, 30 milligrams daily for 14 days. So it's 30 milligrams daily. Let me just see for 14 days. 30 milligrams daily for 14 out of 14 days. Right? Anything else? The first same week, any no better after 7 days treatment. Patient. So, painful, difficult swallowing, persistent vomiting, abdominal mass, plasma, vomit, stool, weight loss, right? HV is called human men, new pain, and more than 50 years, or family, instead, history of stomach or esophageal cancer. Okay, so that's fine. Musculoskeletal. So if it's musculoskeletal, you give ibuprofen. So Brufen would be 400 milligrams, 8 hourly, right? So right? It was 400 milligrams, 8 hours, 4 up to 5 days. Okay, so we have muscle problems. So it's very important that you have your ibuprofen, 100 milligrams, day, 8 hourly. Okay. Okay, so the ibuprofen, and then also a follow-up, right? So follow-up is very, very important. If the pain persists more than 4 weeks, we obviously have to refer the patient. Okay. Okay. So that's basically it for the approach on my approach to chest pain. Okay. So that's in terms of the pack model. Okay. So another way on how I can personally quantify chest pain. So let's say we have chest pain here in the middle. Okay, so let's say we have chest pain. Okay, so let me just see if I can not take this box somewhere. Okay, so we start off. So I go chest pain. Okay. So now we know, okay, it's either an emergency or it's not an emergency, and we have certain risk factors to actually help us. We do the ECG, it could be any of those things. I mean, chest pain is very, very, very vast, okay? So, okay. So in terms of the classification of the chest pain, let's first look at cardiac causes for chest pain. So, cardiac causes for chest pain, they could be, as we said, IHD is the common one, ischemic heart disease, acute coronary syndrome. So that's your ST elevations. Then we speak about, is there any infection in the heart, right? Such as a pericarditis, right? Pericarditis. Then you think of aortic dissection. Okay, then my approach in terms of respiratory causes for chest pain, going from upper to lower, I'm thinking of asthma, right? Thinking of pneumonia. Okay. TB, definitely. Okay. A pneumothorax. So pneumothorax and pneumothorax, pulmonary embolism, even a pleural effusion. Okay, so working our hours from top, going down asthma, pneumonia, TB, um, a pneumothorax, a pulmonary embolism, or pleural effusion definitely could be a cause of chest pain. Okay, then going further into another system, we can take the musculoskeletal system. So in the musculoskeletal system, you get something called, you just see, so musculoskeletal system. So you get something called costochondritis, right? So costochondritis. A hip fracture could cause it, muscular pain, also maybe trauma. Okay, so it's either infection or trauma. Infection causing costochondritis, and trauma which causes muscle pain, hip fractures, right? All of those things, right? In terms of other possibilities, so we think of the brain, right? So maybe there is psychosomatic stress or anxiety or neuropathy, right? Then we can also go to we got the lungs, the heart, muscular system. What about the stomach, right? Common things in the stomach is gastroesophageal reflux disease, or even peptic ulcer disease, PUD, right? So there's an ulcer in the stomach, and that causes the reflux and dyspepsia, as we spoke about earlier on with dyspepsia. And now to manage, we know now how to help manage the dyspepsia. And that all could be enough differential for chest pain. Another system we have to think about is the immune system. Okay, so total body and right here the immune system. So in the immune system, we think of things such as systemic lupus erythematosus, SLE. They're saying in sickle cell crisis, but I want to add here anaphylaxis. So interesting that anaphylaxis, anaphylaxis. That's an anaphylaxis immune system. Anaphylaxis also causes chest pain as well. And the last thing I want to mention, the second last is the endocrine system. So let's call it the endocrine. So the endocrine system, you think of hypo or hypothyroidism, which could be a common cause. So hypo or hyperthyroidism, right? So hypothyroidism could cause chest pain and also a porphyria, which is not common. Neuroplastic pain can cause chest pain, such as a carcinoma. Okay, so just think of neoplastic pain, right? Neoplastic, um, and that's your carcinoma, right? Your cancer. Because the cancer could be in any particular system. Okay, so that's my approach to chest pain. Okay, so my approach to chest pain is that it's so just as a recap in total or in totality. Okay, it's load shedding. Okay, so just as a quick recap. Okay, where is it now? Okay, so as a quick recap, chest pain could either be an emergency or not an emergency. If it's an emergency, you look at your vital signs and you look for any factors contributing to an emergency. So with certain risk factors as well as the presenting problem. Okay. Um, so or it could not be an emergency. If it's not an emergency, also check for certain factors on whether it could be either ischemic heart disease, whether it could be a dyspepsia. Um, Ischemic heart disease treatment, I will speak about when we do an approach to ischemic heart disease. Dyspepsia, you have to stop insane and stop certain risk factors leading to the dyspepsia, such as smoking and alcohol. Uh, for medical treatment, you give lansoprazole. And then for we also have to think of tender costochondritis, which is a musculoskeletal issue, and that is you give ibuprofen for that. Then, obviously, if we're in an acute setting, we have to do an ECG. Okay, ECG could either be abnormal or normal. So ECG could show signs of ST elevation. Then we think, okay, this is definitely ischemic heart disease. We're going to manage ischemic heart disease. Or it could be a normal ECG. We have to ask further questions. Is the chest pain while lying down? Is the chest pain um is the chest pain on palpation? Is the chest pain associated with shortness of breath? So in an acute setting, how do you manage this chest pain? So firstly, oxygen is very important. If you see that the patient needs oxygen, if the SAT is below 94. In terms of blood pressure, if it's high, you give amlodipine. If it's low, you give sodium chloride. If the patient is short of breath and is pain on one side, think of a tension in the thorax to insert the ICD. If the patient is short of breath and the patient has a fever and is coughing, you think of a pneumonia, you give ceftriaxone. Then you also need to refer. Referring is very, very important, especially in an emergency situation. And then I got a table for myself for a generalized approach to chest pain. We can start off from the top. So in terms of the neurological factors, you have generalized anxiety, uh, right? Uh, Cardiac problems. So you think of blockage in the arteries, coronary syndrome or IHD. Think of infection, pericarditis, myocarditis. Think of aortic dissection. For respiratory problems, think of asthma, pneumonia, TB, pneumothorax, pulmonary fusion, pleural effusion was pulmonary edema. In the stomach, GORD is a definition of ischemic ulcer disease. In muscular system, you think of costochondritis as well as trauma, fractures, muscle pain. Okay, the immunology, you think of SLE as well as anaphylaxis. In the ground, you think of hyperthyroidism. Okay, and then okay, yeah. So I think that's it for my approach to chest pain. Thank you, everybody, for watching this video.